record. And off we go. Welcome to your Zoom call. Number of questions submitted, so let's get started. Nothing really new on the member site except we have a new course. This chronic disease and autoimmune course right here most aptly pertains to cancer, because I have said for over a decade that I think cancer has autoimmune components to it, so that can be beneficial. Secondly, that just because we have a disease like cancer doesn't mean that we don't have other comorbidities that quite possibly could have led to our cancer, or at least participated in the precipitation of the disease. So to study other things, especially autoimmune conditions, seems relevant. So if you have some time to kill and you can stomach listening to me, there's a whole bunch of new videos in that course. Okay, so first question, a long one. Follow up to last week. Shoulder issue, rotator cuff. Got an MRI and on prednisone prep last week. Tuesday, 12-day, 40 milligram per day taper. 4 days before the scan last Tuesday. Sorry, every time that beeps, I think you guys hear that beep. That's somebody trying to get in. They did a cervical and cervical CT scan, I think, and a lot of degeneration at C5, C6. Results showed more degeneration and nerve issues, ruling out rotator cuff. C6 affects the neck, arm, and thumb. So you want to understand the nerve pathways. If you make a okay sign with your hand, like if you're making an okay sign, if you did it with your left hand, it looks like the number 6. So you got the other fingers up and you got the okay sign. That's how you remember that's your C6 nerve. It actually affects half of your longest finger, and then all of your pointer finger and your thumb, and up the lateral side. So if you're standing in a anatomical position, it's the lateral side, the radial side of your arm. Possible issues came up with vertebral bodies, bone marrow, multi-level scattered vertebral stir hypersensitivities with corresponding T1 hypointensities, most pronounced at C5, with T2 stir hyperintensity and ventral epidural space measuring 10 millimeters in craniocaudal dimension, and more subtle T2 stir hyperintensity in the ventral epidural space behind the C6 vertebral body. Suspicious for epidural spread of tumor. No compression fractures. So let's back up here just a little bit. So if you do a CT scan or an MRI and you have a lot of degeneration, you could have degeneration. So just about everybody, as we age, we have degenerative disc disease. That is a degenerative arthritis, or used to be called wear and tear arthritis. That's common. It's almost in everybody. That's how I used to be 6'2", now I'm 6'1". You lose height of your disc. That's called loss of imbibition of your disc space. That's normal. So this degeneration is normal. A degenerative disc is not pathological, meaning it's not from a pathological disease like cancer. So metastasis of cancer would not cause this. Now understand, you could have this, plus you could have metastasis of cancer. So when they're talking about stir hyperintensities, that's talked about possible increased metabolic activity because of possible metastasis. So when this is listed, they're thinking about metastasis. This piece does not have to do with metastasis. This is possible metastasis. So if you have metastasis to the spine, that can cause issues, decrease calcium in the vertebral bodies, and you could get some narrowing of the vertebral body without complete destruction of the vertebral body. Destruction of the vertebral body would be a pathological. And that can be, enough on top of this to start to cause morbidities of pain. So pain that radiates through pathway, the peripheral nerve pathway. This person goes on to say there were no compression fractures. So good, that would be more later stage. Remember, when you have metastasis to the bone, it's lytic, which means it breaks down the bone, it's eroding the bone, bony erosion, and then you end up with lack of bone density. And if it's a weight-bearing bone, you can end up with a compression fracture. It's called a pathologic fracture. Okay, so question is, could having the trauma and previous prednisone, do you think this could be affecting the scan? No, I don't think that would affect the scan. So I don't. The hyperintensity is what they're concerned with possible metastasis. Scheduled to do Prenuvo in a few weeks. Not too sure if that will be any cleaner or not. Well, there's still debate on that, whether that'll be cleaner. I think that's a good thing to do. I think just more testing would be good. There's zero invasiveness with the Prenuvo scan. I do have slow differential metastatic disease scattered throughout the vertebral bodies, but no pain anywhere else. An orthopedic guy said that C5, C6 is what's causing the arm and shoulder pain. Yep, I would agree. Doesn't mean that, so don't think that just because a CT scan of your shoulder ruled out rotator cuff, all they're looking for is a tear. So if they don't see any tear in the rotator cuff, they're instantly ruling out the rotator cuff. Well, you can still have muscular strain, a ligamentous sprain that they won't see on MRI. So doctors equally make the mistake too that, oh, you have cancer. Oh, we don't see any rotator cuff tear. So it's probably because of the metastatic disease, and that's what it is. So don't let them jump to that conclusion completely either. And though you might have some metastasis, some increased intensity in different areas here, it doesn't mean you don't have a comorbidity of a muscle sprain or a ligamentous strain. Flip that around, and that could be the real issue. So don't give up on treating it from a musculoskeletal point of view. Why did you expect that my alpha fetoprotein tumor marker test will take a while to drop after surgery? Well, I didn't. If I said that, I misspoke. I didn't expect it to. It's just that I've just seen that sometimes it can take, a few weeks for your tumor markers to drop post-surgery. Now, I did a brief, search on the literature on any data on this, and I just can't find any studies on when tumor markers will drop and post-surgery. So, matter of fact, there's very little on the AFP tumor marker with breast cancer. It's literally almost most of the research is done on liver cancer. So it's hard to find any research on this stuff. So it's very difficult. It's just through the years of trying to help people with this, my what I've noticed is that tumor markers don't necessarily drop suddenly post-surgery. So that's what I meant to say. Why might other tumor markers rise after surgery? Again, you remember that, tumor markers are just one test and it's not perfect. The only data that you can really find on what causes tumor markers to rise is the use of chemotherapy. And that certainly doesn't happen every time. We have patients probably on this call that did chemotherapy and it didn't cause their tumor markers to spike. But I'll tell you for sure, over the years, I've seen that lots of times where people would start chemotherapy, so their tumor markers literally just went skyrocketing. And some people's body doesn't respond the same way. So all I'm saying is that there's not really any data that says that it's a bad thing that tumor markers are dropping quickly. There's no data on when tumor markers will drop and how much they will drop after surgery. There's just it's just speculation at this point. Most recent labs show free T3. So when a person's talking about this, free T3 is a thyroid marker. So that's free T3 is your active thyroid hormone. So it's at the low end of range, 2.0, and my free T4 is high outside of range. And my ND said she had never seen such high free T4 with low T3 without external supplementation to drive up the T4. Well, I would say that your ND probably doesn't see a lot of thyroid patients then, because this scenario of low T3 and high free T4 is called the underconversion effect. So understand your thyroid gland makes over 90% of the hormone that the thyroid gland spits out is T4, which is not the active form of the thyroid hormone. The active form is T3, and it's free T3. Understand that 90% of the T4 and 10% T3 that's spit out by the thyroid gland is also protein bound. It's not even neither one of them are in the active form yet. And then T4 is converted by an enzyme called 5-deiodinase in the liver and in the gut to become bound T3. And then the protein is shed and you have active form of T3. So when a person has high free T4 and low free T3, that means they're not converting T4 to T3 adequately. That is usually the possibilities of that. That's again called underconversion effect. It's not converting T4 to T3, and it's usually because the person has Hashimoto's, and they may actually be attacking the 5-deiodinase enzyme that converts T4 to T3. Number two, they could have gut or liver issues, so they're not producing that enzyme and they're not getting the conversion. So you have to look at antibodies in the gut, food antibodies typically that would cause that and lead to leaky gut, other things too. So that's really, this is called underconversion effect. It's very common with Hashimoto's. I don't remember who asked this question, but you should make sure that you are getting TPO antibodies and thyroglobulin antibodies tested to as well, because pretty much guaranteed that if you don't know it already, you have Hashimoto's disease. So, and that is an autoimmune thyroid. She wanted me to check iron content of all my supplements, but I don't see anything significant there. Does this look wacky to you as well? Any ideas for cause? So underconversion is caused from a person being in Hashimoto's and they have an attack on the 5-deiodinase enzyme, or they don't have the conversion going on in their liver or in their gut. because of liver and gut issues. Very common with Hashimoto's. Hey, you can learn all about this in this course right here, this chronic disease. I have the module 6, bonus module is all about Hashimoto's, more than you'll ever want to know. For SEACT, liquid concentrate protocol, I understand to use 1 tablespoon in hot water sipped over 15 minutes. I usually use 8 ounces of water. What if I use room temperature water? Also, what are the consequences of drinking it all at once, especially if I forget to sip it over 15 minutes or I'm in a hurry? Yeah, this is a hard one because that was just a recommended protocol that was always recommended for SEAC. And it was typically you sip it over 15 to 30 minutes, you make a tea out of it. Is there a benefit to that? Don't know. I don't really know. I've had patients over the years that they mixed it in their smoothies. It's like I don't think they had any ill consequences. I mean, I don't think it did work any less. They're just herbs, and just because they were mixed in a tea at one point in time doesn't mean you have to do it that same way all the time. It's like the old story of the lady who cuts off the end of the roast before she puts it in the pan, before she puts it in the oven. And her husband said, "Why do you do that?" And she said, "Well, because mom always did it." Well, call her and ask her. And she called her mom and said, "Why do you always cut the end off the roast before you put it in the pan, before you put it in the oven?" She said, "I don't know, grandma used to always do that." So she called grandma. "Why do you always cut the end off the roast before you put it in the pan, before you put it in the oven?" And grandma said, "Because the pan was too small." So sometimes there's not always a good reason for why it's done. We just try to logically think through it. And I don't think that doing it the way you're doing it is necessarily going to cause any different effects of it. Sometimes there's a physiological reason for it, and I could kind of rationalize through that and some of these things, and sometimes I can't figure out any physiological difference. Certainly taking any nutrient over a longer period of time, you're going to have maybe better absorption of it. And if you take a nutrient and break it down into 3 doses over the day, we've talked about every nutrient in your body has a half-life, meaning that if I take everything, that I'm supposed to take at 6 o'clock in the morning, there's a good chance at 6 o'clock at night, I don't have a whole lot of that nutrient circulating in my bloodstream. So, spreading out the dosage definitely has physiological benefit. I don't know if sipping it over 15 minutes versus gulping it down has much. I've been taking OptiAdrenal. This is a Dr. Brimhall supplement for a number of years. I'm wondering if by now I shouldn't need it anymore. What product does Connors Clinic have that's comparable to OptiAdrenal? Well, OptiAdrenal is kind of like a multi. It's got some adaptogens in it for the adrenal gland. It's got some B vitamins in it and such. The problem with like a multi supplement that has a ton of stuff in it is that it has a lot less of everything in it because you only have the same size pill to put stuff in, right? So it's definitely it's typically used as an adaptogen to help support adrenal gland, and it's got the B vitamins in it to help support the adrenal gland. It's a good supplement. I wouldn't use the OptiThyroid product that they have, but the OptiAdrenal is a good supplement. I don't think there's any reason why you'd have to change it unless you're like just trying to cut down on supplements. But like the adaptogens that we have, there's more of them in because there's only like some of them have 3, some of them have 5 nutrients, specific herbs in the pill, so you're going to have a greater concentration versus having 40 things in a pill. You're going to have a much lesser concentration or something. But if you're doing well with it, I wouldn't say to change it. I think it's a good product. I recently stumbled upon a test called HTMA, hair tissue mineral analysis. What are your thoughts on this test? And would you recommend it? So if it's a hair analysis test. So you take a clip of your hair. So I'm just guessing because I don't know what this test is. So just by the name of it, I'm sure that it's a clip of your hair and you're sending it in for mineral analysis instead of for heavy metal analysis. I would say it's not a good test for mineral analysis, and hair analysis is not the best test for heavy metal analysis either. But there isn't a lot of other good tests for heavy metal analysis. So there is a urine test for heavy metal analysis, but you're taking a strong chelator like DMSA, kind of in overabundance to pull it out of the tissues to dump what you can into the urine. So then you're measuring it. I think that's a very poor test because you can make a person really sick with that test. So I think hair analysis is the best option that exists for heavy metal testing. If you want to really assess mineral analysis of in your body, you really have to do an intracellular nutritional test. I forgot the name of that test off the top of my head because I don't ever use that test. Hair analysis mineral test, I'd say no, do not use that. It's not going to be accurate at all. Second part of the question, I've had a Dutch test. So a Dutch test is a dried urine analysis test for hormones and your cheek swab test. I'm wondering if this test would offer any additional benefits. I'd say no, don't do that test. There's a lot of other tests that could offer benefits. I'd get out of the courses if I were you and look at what you're trying to analyze and the information that you're trying to gain. And as you go through the courses, something might spark your attention like, oh my gosh, I should do this mycotox test because I was exposed to, mold of so much in my life. And maybe is kind of a hidden issue. Well, then, that's one of the reasons why I created these courses is for you guys to be able to study on your own and go, wow, this could be a possible solution for myself too. So get out there, you have free access to all those courses. You had recommended Cleanzyme for Tim, 3 per day based on the last cheek swab. Initially, just gave it to him 1 per meal along with other supplements, gave him diarrhea. So now we're giving separated from meals. Should it be separate? You don't have to take that separate, but when I think about the physiology of it, probably might work better separated. So remember, the Cleanzyme is the oxygenated magnesium. So Cleanzyme, though it does have Astrozyme in it, which all the US enzyme products have Astrozyme in it, even though the Astrozyme, which is their proprietary enzyme, is not really, you're not taking the product for the Astrozyme. It's just helping the product work better. And the active ingredient work better. The active ingredient in Cleanzyme is the oxygenated magnesium. And I spoke about this a few Zoom calls ago, that the Harvard scientist who has the patents on oxygenated magnesium, the only company that uses his full proprietary utilization of his patents is US Enzyme. So there's other oxygenated magnesiums out there, but they're not using his full patented formula, which they're not getting the benefits. So what's the purpose of oxygenated magnesium? Is that it will kill pathogens in your gut, and it has the potential of killing tumors in your gut as well. So that's what tested for Tim last time. So maybe it might be better to take that on an empty stomach. He's on 3 different enzymes, 1 to help digest food, 1 to eat on the tumor, and now this Cleanzyme that we don't know what it's for. So hopefully that helps. Doesn't seem to do well with enzymes. It doesn't do well with enzymes, probably because, so defines on what unwell is. So it's giving him more gas and stomach ache at times. It's probably because it is doing well. So usually when a person says, I don't do well with enzymes, even if they don't have any type of cancer whatsoever, it's a sign that they need more enzymes. So that's almost 100% of the time. Certainly with a cancer patient, if they're getting more symptoms by taking the enzymes, it's, in my opinion, it's really because the enzymes are actually working to break down the tumor. And that's exactly what we want to do. So we want to try to get up to dose with those. Now that I'm done with 7 weeks of radiation and 4 rounds of light chemo for my squamous cell tonsillar cancer, what are the best things I can do to help clean up my system and stimulate normal saliva production? Well, the radiation really does a job on your parotid gland, and that is hard for saliva production. There are some parotid glandular products out there, one by Biotics Research. You'll have to call it in because Biotics is one of the companies that contacted us, and they don't allow any internet sales anymore. So they don't allow their products to be viewed by anybody online. So you have to call in. We can still sell them, but we can't show them on our store any longer.
On the side of
So just know that you could call it in. The parotid product might be good for you. It might be good to do a cheek swab again too. Lots of mucus now. They said to expect a dry mouth. I'm still only eating via feeding tube. Just saw speech therapy person. Okay, good idea to do it maybe a cheek swab. I don't get it. Okay, just FYI, I was discussing Pernuvo with my ND, and she mentioned they can do less than full body. Yes, they can. You don't have to do a full body. You can do partial, whatever you're looking for. With breast cancer for about $1,000. Yeah, I think they even post their prices online, but at least you can call them. So that's a decent price, I think. If you went and had to pay out of pocket just for an MRI, I think it'd be at least $2,500. So, and no MRIs are full body; those are only sectional. I'm on a low carb diet, 20 to 30 grams a day. Is grass-fed butter to help substitute for little carbs okay? What fat other than butter for long term to get enough calories? I am very slim already. So if cancer is being driven by dairy, can you have a little butter? Yes, I think you could have a little butter. You don't have to be that strict on your diet, but everybody's definition of a little butter is different. My grandson will take a stick of butter and take a bite out of it, but you can put a lot of butter on a piece of bread too. So it's, just having that balance. Certainly eating grass-fed butter has other health benefits. It is a good fat. So that's, something to think about. It's better than margarine or these crappy garbage fats. So eating some grass-fed butter, I would say, yes, you could eat grass-fed butter. As far as getting calories, you want to be, if you're losing weight, then you have to kind of flip the switch you have to get calories. You can't be in a state of cachexia where you're losing 2 to 3 pounds a week. That's just very unhealthy. So you have to think about doing some getting back to some more complex carbohydrates. Now that will throw off your grams per day of your low carb diet, but you can't keep losing weight if that's your issue. Recently read an article about heat shock proteins and cold shock proteins produced by cold or heat therapies. Are both of these beneficial for cancer patients? I know that infrared saunas are good. Do they create heat shock proteins? Megan has suggested I could do mistletoe therapy. Okay, that's a different question. So yeah, there's just not a lot of research out there, to be honest, about hot and cold therapies for cancer patients. Matter of fact, you won't get a research paper. You won't get a research grant, or you will not get a research. In order to do research, you have to get this number and apply for it if you're doing human research. And then to get it published, that's a whole other story. And if you're not tying it in with, using cold therapy with cancer patients along with chemotherapy, you're not tying it into chemotherapy. You're not even getting PRP. That's the approval process for doing research. I was involved with a research project about 15 years ago, and getting a PRP was just really, really difficult to get. It wasn't on cancer, it was on something else. But so I don't know if there's a lot of research out there for these kind of things, at least not in the US. There is some data with infrared saunas and infrared heat and using heat on breast cancer, but not a lot of other cancers. But I do, there's anecdotal evidence that using both cold and hot therapy can be beneficial for cancer patients. And I really think the cold therapy is beneficial, not that it kills cancer unless you're doing isolated cryotherapy on a cancer. But I'm talking about what you could do at home, like cold bath therapies. It helps decrease inflammation. So that's a huge benefit for anybody, whether you got cancer or not. Megan has suggested I could benefit from mistletoe therapy. In your opinion, is this a good therapy, and what type of cancer patients can benefit from this? Well, any hard cancer patients can benefit, and I mean not a blood cancer patient. So you have a physical tumor, they can benefit from mistletoe therapy. Mistletoe therapy is an immune stimulant. You could do IV mistletoe therapy, or you could do mistletoe therapy that you do at home, and it's an injectable. You inject it into your belly and you get this reaction, and it's basically an immune reaction. Anybody can benefit from it. So I wouldn't hesitate about trying it if you're kind of stuck with your care protocol. I need to add notes on my C5, C6 issues from the earlier question. The C5, C6, and C6 re-demonstrated mild spinal canal stenosis with deformed spinal cord with marginal cerebrospinal fluid surrounding the cord, plus severe right and moderate to severe left neuroforaminal narrowing. So your spinal foramen is where the nerve root comes out on both the left and right side between the two vertebrae, and it can become narrowed and causing impingement for many reasons. It could be arthritis into the spinal foramen. It can be loss of disc inhibition, like I mentioned. So you have a decrease in disc height, therefore the foramen is going to be impinged. You can have a disc bulge into the foramen, and that can cause impingement. So stenosis just means impingement. So usually stenosis is an old word used, usually at least used to be used from bony impingement from arthritis, but it's not always used that same way. Impingement of the bilateral C6 nerve root secondary to severe desiccation. So desiccation is loss of bone density. Moderate to severe disc osteophyte complex. So osteophyte is a spur of a bone. So disc, severe disc osteophyte. So osteophyte is not from a disc, but osteophyte complex has to do with, so when they say disc osteophyte complex is loss of it's a disc bulge with bony spur formation. That's arthritis. So that's what degenerative disc disease is. That's what they're probably talking about with disc there. And a degenerative arthritis, that's the osteophyte complex is. Mild ligamentum flavum runs right down the in front of the spinal cord, right down the center of the foramen magnum and all the way down your vertebrae. Hypertrophic calcification. So you got increased calcification, severe bilateral uncovertebral joint. So your uncovertebral joint is your lateral joints of that form your joints that you when you bend from side to side. Hypertrophy and mild bilateral facet. So this is your facet joints. You have arthritis in your facet joints. And an MRI with contrast, and the possible tumor issue came up as a possibility and stated contrast to confirm. So everything that we talked about here has to do with degenerative arthritis, degenerative disc disease. This is not pathological in the sense of cause from cancer. This has to do with post-injury wear and tear. This is not even caused from a inflammatory arthritis like rheumatoid or something like that. This is degenerative arthritis. So degenerative arthritis is evident in a person post-injury. Let's say they did a lot of work lifting and with their back, maybe they had an injury in college, and now it's just the degeneration starting to come back and haunt them. What I need is your opinion or suggestions. They will want a contrast or CT contrast to confirm, to know if the tumor is spread. So again, you could have something going on with the cancer underlying this as well. And I think you should rule that out. I'm not sure if removal will be any clearer. Yeah, I'm not positive either. If you got that scheduled, I think I would keep that schedule and do that. A PET scan might be helpful. You might ask them about that, getting a PET scan to see what that would show. I'm at a crossroads of what to do. It's taper of prednisone. I am 5 days away from finishing and no pain yet. Okay, that's good. I would keep running the RIFE programs for pain, keep running the accelerated healing program on the RIFE that we talked about last week. I'd be using some CBD lotion too, I would. And on the skin, that can be beneficial. I'd be upping my curcumin big time, upping my boswellia and other anti-inflammatory flavonoids and stuff. I'd up that big time. Concerned about the radiologist saying possible tumor spread. I mean, anything is possible. It's possible, just given your history that that's there, or it could be just solely because of musculoskeletal. Should the biotoxin binder be taken with food or not? Some of your nutrition, I'll be honest with you, I'm not very good at trying to separate out with my personal supplements with food or not. I'm not very good at taking my personal supplements because I get so busy I forget. So that's not a good thing to admit to all you people, but you guys, some of you are really good at taking your things, and I don't typically, except when it's really important, tell people to take things with food or without food, unless it's really important. A lot of your nutrition are food products per se. They're whole food in nature, so taking them with food really doesn't make any difference, and it can actually be better. Some things taken with food can help with your stomach, and even things that maybe should be taken on an empty stomach. For a lot of people that are really ill, it hurts their stomach if they take it on an empty stomach. So taking it with their food could help with stomach upset. And, if their stomach gets upset when they take their stuff on an empty stomach, they just won't take it. So the binders probably better taken away from food. So I would say, if you're really good at it, I would take the biotoxin binder away from food. Some things, like I tell you, if I have you on a digestive enzyme for food, you take it with your meal. You certainly take HCl with a meal, not on an empty stomach. And some things, I have you on an enzyme therapy, I say you have to take this on an empty stomach. It's just a must on some of those things. Is 7 weeks post-op okay for lymphatic massage. Doc doesn't want it to push fluid out of the scars and drainage holes to reopen with them. I just have paper tape over my incisions or scars. I don't think there's a problem with it as long as you have a trained massage therapist who is certified in lymphatic massage, and that I personally would have them stay away from your wounds. I would agree. You don't want to break things open. We had a patient once that had really botched surgery, horribly botched surgery, and it was the surgeon's fault. But I have seen the results of a wound that got opened post-surgery and just could not heal. So I would just be more careful than not about that. Anyone have any information on the compound called EBC 46? I think it has an effective in a clinical trial as cancer treatment for dogs. So, see if that's the same thing that we used to carry. Yes, we used to carry that. We could only get it from Australia. It's blushwood berries tincture is what it is. We started carrying that because I saw a study that was beneficial for breast cancer. And I just didn't have enough people on it to really notice what if I was happy with it or not. And then with COVID, we couldn't get it anymore. So they weren't shipping to the United States through the years of COVID. So we ended up taking it off our store. So, but it's just an herb that you can only get over in Australia. It's called blushwood berry tincture. I believe I'm looking, I just Googled it. I think you can order it online. So they must be back in business. They were just closed during COVID. All right, I'll say good night to all of you. Hopefully you're getting better weather, and just know that I'm praying for you all. Please get on the courses, and if you have questions about it, you can schedule a time with me to think about any tests. Thank you very much. Bye-bye.